That's great. Thank you very much. You can hear me well, Cassie, for the recording?
Yes. Yep.
Great. So we're going to talk today about cartilage restoration. Can I save my own knee? And let's make sure this is working. So my current practice, I'm a sports medicine orthopedic surgeon, and I predominantly take care of knee and shoulder problems. And I'm the director of the cartilage restoration program, both at Rothman, but in addition, we started a cartilage restoration program at Bryn Mawr Hospital, which was really the first in the area and has become pretty much the highest volume center in the tri-state area. And I'm also do active research in the field of cartilage restoration. So the objectives today are to do an overview of cartilage injuries with predominantly a focus on the knee, although if there are questions, we can address it because these do apply to other joints. What are the treatment options available? Some about what's on the horizon for treatment of cartilage injuries and how these can relate to you and if you're having current problems. So first, it's really important to understand a little bit of the anatomy if we're going to talk about cartilage injuries. And this is a schematic of the knee, both from the front on the left and from the side. And when we talk about the articular cartilage, it's basically the smooth covering of the bones. And we have this in all of our joints that move back and forth, and what's called an articular joint has articular cartilage, which is this white shiny lining, and that provides a smooth surface. And so in the knee, we have it both underneath the kneecap, plus on the end of the bones, on the end of the femur, and on the end of what's called the tibial plateau. And the function of the articular cartilage is really to provide a smooth gliding surface for the joint. So on the photo on the left, there's a nice smooth white cartilage, and this is what we see during arthroscopy, which is normal. And then on the right, there's basically a speed bump in the road where there's missing cartilage, and that orangey surface is essentially cartilage missing with it worn down to bone in that spot. So what does articular cartilage do? It distributes load across the joint. It tries to minimize peak stress so that it gets diffused and distributed, and it really provides a low friction surface. Now, we also, when we talk about cartilage injuries, there's the meniscus, and many people, if they've injured their meniscus and they say, I tore my cartilage, typically we're talking about the meniscus when that happens. And the meniscus are the cartilage rings that live on the sides of the knee joint. So there's one on the inside, the medial meniscus, and one on the outside, the lateral meniscus. And this is just a gross specimen looking straight down with kind of the femur removed at these cartilage rings and what they look like on the inside of the knee. And then this is what I see arthroscopically when I look at a normal meniscus. When we put in a little camera, I can see the meniscus. That's the inside, that's the outside, and these are these cartilage rings that we can see. And in this case, these are completely normal. So what does the meniscus do? It works in load sharing, it's in shock absorption, it provides congruity of the joint, and it does provide some stability to the joint as well. And then finally, just because we're going to talk about some surgical techniques, and arthroscopic surgery that many of you are familiar with is basically where we use a very small incision about the size of a pencil point, and we're able to insert a camera, and then we can look around, and on a TV camera, we can see what's going on inside of a joint, and there's many instruments to allow us to do different types of repairs within the joint. So this is what we see in a normal knee. So this is the underside of a normal patella, and this is what it's supposed to look like when you have normal cartilage. It's nice and white and smooth and shiny, and this is essentially a normal joint surface. And this is the outside of the knee, and again, this is a normal meniscus that I'm probing, and the cartilage surfaces are nice and white and shiny, and there's absolutely no damage in that area. So when we think about normal articular cartilage, it's pretty much impossible to duplicate. It's thin, but it's stiff to compression. A normal synovial joint that hasn't been injured can function for 80 years or more, and it has the lowest coefficient of friction. So when we think about joint replacement and all the different surfaces that get used for joint replacement, none of them have a lower coefficient of friction of normal cartilage that God gave you. So the biggest problem is that it's a fact that articular cartilage doesn't heal once it's injured. And the reason is because it's avascular, it really has no blood supply. And once it's injured, there's no undifferentiated cells that come in to help heal that area. So unlike all these other parts of the body where when you sustain an injury, the first thing that happens is your body brings in undifferentiated cells to heal, and these aren't available when cartilage is injured. And this is why there's so much interest in things like stem cells and other things, because that's trying to provide some undifferentiated cells to allow healing. So when we think about articular cartilage injury, I really look at it as a spectrum. So on the left, this is what I'd call a focal chondral defect, which is basically a small little pothole in the cartilage. And then over to the right, this is advanced osteoarthritis, where it's completely worn down the bone on both surfaces. The meniscus is missing. So these injuries, typically lie along a spectrum from anywhere from smaller injuries or focal defects to advanced arthritis. And this is really, we've started where this is what we would fix initially with things like cartilage restoration, and we've really advanced. So we get closer and closer to being able to fix what's on the right side of your screen where there's advanced arthritis. So how do cartilage injuries occur? Well, there's biomechanical issues. It includes everything from obesity and malalignment, so the joint's not lined up correctly. You can have joint laxity, so people who get injuries to their ligaments typically create too much stress in certain other areas and can get damaged. There can be muscle imbalance and strength issues. There's traumatic injuries, so I see people who injure their knee through sports or motor vehicle accidents or work where they traumatically damage that cartilage surface. Some patients have had prior surgery that can create injury, and sometimes it's just genetics. It's really similar to osteoarthritis, where people just have some poor collagen and joint structure, and these cartilage surfaces can get damaged. What type of symptoms do we see? Well, it includes pain. So that's by far the most common thing I'll see with someone with cartilage damage, is they're going to have pain in their joint. They very typically can get swelling where the knee swells up with fluid. There can be mechanical symptoms where it catches or locks, and you can get giving way. Most of the time that's more because you hit a spot that hurts and the muscle fires and it wants to give out. But these are all symptoms that we see. And many times what type of symptoms we see has to do with what we call what the shoulders are like. So it's like a flat tire like a tire that hits a pothole. If the pothole's small enough, you're not going to feel it. But if the pothole's big enough, you're really going to have a significant effect. And the other thing is that when I see patients who have swelling in their knee and they're not sure what it's coming from, one of the first things I think about is that they have this type of cartilage damage in there that's creating it. So how do we manage cartilage damage? I mean, this kind of summarizes all of the treatment algorithm that we can go through. And we're going to touch on all these things. It includes pharmacologic treatment with medications. There's physical modalities, including exercise, bracing, and weight loss. There's local pharmaceuticals, basically injections, which include steroids, hyaluronic acid injections, and then biologic injections. And then there's surgical treatments, and we'll talk about those as well, since I am sort of an expert on the surgical treatment of cartilage disease. So first of all, when it comes to exercise and cartilage damage, I mean, when somebody first comes in and they've had an area damage or they're having pain from chronic damage, activity modification is an important part. But we really want to make sure that people continue to exercise. Lower impact exercise is good for the joint. This includes swimming, biking. walking. Many times I'll have patients doing, elliptical and other lower impact activities. And there is scientific proof. There's been all types of different research studies have been done to show that exercise is good for the joint and can benefit the symptoms from cartilage damage. Formal physical therapy is something we utilize a lot in orthopedics, and especially for this. There's a whole variety of reasons on why it helps. It depends on what symptoms people are having. When people have this sense of buckling, as I mentioned, and when it's not coming from a ligament injury, it's very commonly from weakness of the muscles. So whether it's quadriceps weakness or weakness all throughout the lower extremity and the core, all those things can cause muscle imbalance and can aggravate symptoms. So physical therapy can really help with muscle strengthening and this muscle imbalance. It can work for stretching the joint to improve flexibility. It also increases proprioception, which is your body's ability to know where it is in space, and that can help. So for all these reasons, physical therapy is really one of the best first-line treatments we have for people with both cartilage damage or more advanced osteoarthritis. Weight loss. So this can, be a touchy subject for a lot of people, but it's really important to discuss because when you think about the stress that gets put on a knee as a weight-bearing joint, and as you increase your activity from normal walking to stair climbing to going downstairs and squatting, you start increasing the stress of the amount of body weight force that these joints feel. And especially when you look at something like squatting being 7.5 times your body weight, you know that, every time you lose a pound, it's like 7 pounds off your knee for that activity. So that's why even small amounts of weight loss can really make a huge difference. There's bracing that we can use. The braces that we use are everything from elastic sleeves, which can provide some proprioception, which is that feeling of knowing where you are in space, and warmth. And there's also braces that can provide significant mechanical effects. There's something called an unloader brace, and that's can help. So if somebody has an area of cartilage damage or early arthritis in one particular spot, those braces can take pressure off of that area, and by doing that, they're able to redistribute the force and really minimize symptoms. So if somebody gets a brace that pushes on the outside of the knee, the more normal area, it can take pressure off of that inside where the problem is. When it comes to medications, these are both for pain and for inflammation. There's everything from acetaminophen, Tylenol. There's a whole slew of non-steroidal anti-inflammatory medications. This includes Motrin, Aleve, and all types of prescription medications that can help with both pain and inflammation. There's also other central acting pain relievers. There's what's called Tramadol or Ultram. Muscle relaxants isn't something that we typically use unless somebody really has a significant amount of muscle spasm around the damaged area. And certainly narcotics is something that we really avoid. This is something that you hear about all the time with the opioid epidemic that we're dealing with. And this is really gone out of favor for trying to deal with pain, whether it's from chronic arthritis or chronic cartilage disease. So it's certainly something we want to avoid. Now, nutraceuticals are nutritional supplements. Nutraceuticals are not regulated by the FDA because they're nutritional supplements, so they're not treated like medications. So when you go to the drugstore and there's all these different joint formulas, it can be hard to distinguish what works, what doesn't work, and certainly what's been proven. So probably the most common nutraceutical that's really undergone some study is glucosamine and chondroitin sulfate, and that's been shown to increase glycosaminoglycan production within the joint and some production of hyaluronic acid, which is within synovial fluid. Now, there's questions on whether or not it really produces an anti-inflammatory effect the way that other non-steroidal anti-inflammatories do. And certainly the question is important, is it truly chondroprotective, meaning is it going to protect your cartilage or prevent further degeneration? So we took a look as a research project at all of the different products that were available. This was published back in 2016, but it looked at everything on the shelf, and it looked at glucosamine and chondroitin sulfate and all types of other nutritional supplements that get touted as joint protective mechanisms. And really the only product that was shown to have some scientific proof of its benefit was glucosamine and chondroitin sulfate. So certainly it is recommended that you can consider this for preventing progression of joint damage. So what about injections? Well, first of all, there's cortisone. So I'm sure many of the people on this audience have gotten a cortisone injection. So this is basically a powerful anti-inflammatory and analgesic effect. It typically, we say, provides short-term relief of about 3 months. And, we can use that if we've tried other pharmacologic therapy and it doesn't work. If somebody has a significant inflammatory component to what's happening, for example, I just saw someone today who had a contraindication to taking anti-inflammatory medication. So that's a really good indication for trying to use cortisone to calm down inflammation. Hyaluronic acid injections or viscosupplementation, these are what we like to call joint grease injections. So this is basically been shown because the elasticity and viscosity of synovial fluid in patients with osteoarthritis or early cartilage disease have been shown to be lower. So this replaces that hyaluronin in synovial fluid. So these are done as injections in the office. They're generally 3 injections 1 week apart, although there are some different formulations for hyaluronic injections, acid injections. And I use these both in patients with, everywhere from mild to advanced osteoarthritis, but also for many of my patients with early articular cartilage damage. We'll try this as a treatment method to see if it gets them symptomatic relief. Now, it is important to know that when you look at the severity of arthritis and the effectiveness of these treatments, and this is true of nearly all the types of injections we have, that it does better when there's earlier arthritis. So these patients with smaller cartilage damage certainly do better with this treatment than patients with grade 4 advanced bone-on-bone arthritis, although it certainly still can help those patients. Now, biologic injections, I'm sure, I haven't seen what's going on the chat box, but I'm sure that this is going to raise some questions from the audience because these get a lot of publicity and a lot of interest from patients. So there's really 2 major types of biologic injections right now. There's something called platelet-rich plasma. So platelet-rich, and I'm going to go over both of these in detail. And that's been shown to have a positive effect for pain relief from arthritis. And then there's also this entire concept of stem cells. And I'm going to talk about that for a few minutes as well. But as you'll see, there's really very little data on its effectiveness, and there's different types of formulations. So when it comes to platelet-rich plasma, it's basically a growth factor treatment that comes from whole blood. And it concentrates the platelets to be injected back into a joint. And as I like to tell my patients in simple terms, it basically collects some of the healing juice to be able to be injected back into the knee. So this is something that's done in the office, takes about a half hour to do. Basically, blood gets drawn, it goes into a centrifuge, it gets spun down, and then it gets injected back into the knee the same way that cortisone would be done or viscosupplementation would be done. So the question is, does it work? The answer is yes when you think about pain for both arthritis and for cartilage damage. And it's actually been shown through the literature, and there's some pretty good literature on this, randomized controlled trials that compare PRP to viscosupplementation and other treatments. And it's actually been shown to be better than viscosupplementation in terms of pain relief and how long it lasts. Now, the problem is that what everybody really wants, the holy grail, is does this regrow cartilage? And much of that is unknown. And most of the surgeries that have added PRP, when we think about healing, whether it's everything from ligament surgery to rotator cuff surgery to arthritis type surgery, they really haven't been shown to make any difference in healing. So although we know that this works for pain, when it comes to healing and cartilage regrowth, which is what everybody wants, we really have very little data to support that that's going to happen. Now, what about stem cells? So again, this gets a lot of publicity. There's all types of ads in the paper and everything about what's going on. And so there's basically a couple of different types of stem cell treatments that are discussed. First, there's mesenchyme-derived stem cells, which basically comes out of bone marrow aspirate, or from adipose-derived stem cells, which are from fat. And then there's allogeneic stem cells, which means they come from a source outside of your own body. And that's predominantly amniotic fluid injections, which can be done, which aren't truly stem cells. And then when we think about this can be done either as isolated injections or combined with surgeries that we do. So when we look at some of the data on what is done with this, basically, there have been several studies that have looked at the quality of studies that have looked at these type of stem cell injections, and most of them show some modest clinical improvement, relatively good safety. Almost all studies have shown that placebo effect is a real issue with these, and for patients getting injections on whether or not it's truly providing an effect. And so when you think about bone marrow aspirate concentrate is really the only FDA regulated stem cell type treatment available in the United States. So everything else that's touted as stem cells isn't truly stem cells. And there's a lot of regulation that goes on to concentrating stem cells. And because of that, they're not really FDA approved at this time. So bone marrow aspirate concentrate, or BMAC, is really the one available product that is done in the operating room typically. It's the most concentrated area of these cells is from the iliac crest. It's very expensive because we have to take out an OR room, we have to provide the product. So it's an out-of-pocket cost. No insurer that I know of is currently covering this. Now, the good news is there is data that shows they can provide pain relief at both 6 months and at a year. And we're really, we do this type of aspirate injection at Rothman, but we're doing it in a very controlled environment. We're trying to research all of our patients to know that it's effective, and look at whether or not it's working. So we're using it in really a very selective way for select patients. So then there's cartilage restoration surgery. And a lot of the principle of this is that we know that symptomatic lesions or damage to the cartilage progresses over time, and this surgery can really improve symptoms in both pain and function. So what are the types of things that we do for cartilage restoration surgery? Well, first there's just cleaning up damaged cartilage, which is typically arthroscopic kind of lavage and debridement. There's something called marrow stimulation, which is a reparative treatment to try to get your own body to heal from within. And then there are restorative treatments, including osteochondral grafts and autologous chondrocyte implantation. And I'm just going to touch on each of these type of treatments so you understand the basics of what is possibly available. So first of all, when it comes to arthroscopic debridement, this is not something that we typically like to do unless there's early cartilage damage that's really getting caught or causing mechanical symptoms. Certainly for people with more advanced arthritis, this is not a treatment that we generally recommend because in many cases it can worsen the symptoms. But this is basically cleaning up loose cartilage, and it's designed to improve congruence, remove any debris or inflammatory mediators, and it can be done as a first-line treatment. And for some people with early cartilage damage or one particular area, if you clean up that spot, symptoms can go away. And certainly if you're an NFL football player or an NBA basketball player and you damage your cartilage surface, this is what you're getting done to try to temporize your symptoms, get you back in to be able to play and improve your function. Now, microfracture is a treatment that has really gone out of favor for a lot of surgeons. It's something that used to be done a lot. And this principle of microfracture is basically to fill the area damaged with scar cartilage, which is basically stimulating the bone underneath to help grow fibrocartilage in the defect. So if somebody has an area of cartilage damage, this can be cleaned out to a smooth surface. We essentially use these little ice picks. This is done arthroscopically, and that's done to poke holes in the bone to stimulate that, to fill in that pothole with cartilage from underneath. And it creates what's called fibrocartilage in the defect. And the way that that does it is because it bleeds in that area, and then it's bringing in some of those progenitor cells that we said weren't available to heal cartilage and trying to get that defect to fill in. But we found that there are really only certain select patients that do well with this, and many times the results of microfracture can deteriorate over time. So this is not something that's done for a lot of types of cartilage damage, but just some select damage that we really think will benefit from. So there's also what's called osteochondral grafts. So osteochondral means both cartilage and bone, and these are grafts that can be placed in areas of damage. So there's both an autograft. Anytime we talk about an autograft in orthopedics, that means it's somewhere from your own tissue. So you can take a plug of cartilage from one area in the knee and put it in another. And then an allograft is a cadaver transplant, where basically we take a piece of cartilage and bone from a cadaver and then use that fresh plug to fill in the defect. So as I mentioned, osteochondral autografts, usually we take it from what we call a lesser weight-bearing area, and then we put it into a central weight-bearing area to try to alleviate symptoms. This really also is only done for very small areas of damage, because we usually say this is robbing Peter to pay Paul, because you have to take this cartilage from someplace and put it somewhere else. So it can work well for a very small defect, but as areas of damage get bigger and bigger, it gets much harder to use an autograft technique that will be successful. Now, when it comes to osteochondral allografts, that's not true. So this is a cadaver graft that's fresh. It's refrigerated. It's not frozen. These are tested. So this, comes from someone. It's basically harvested the same way that a kidney would get harvested or a heart, but now we have a cartilage graft, and it doesn't need to be implanted right away the way those live organs do. And usually you have for about 28 days to implant a cartilage graft within somebody's knee. So this is hopefully, usually I do these lectures live and I get to see people's ooh and ah and reaction and things. But now, this is one of the downsides of Zoom, is you don't get to, really engage as much with the audience. But this is someone who's very young, who's got a big area of cartilage damage in their knee, underneath their kneecap, a couple different areas. And then we can take a cadaver, both patella and this is what's called a lateral femoral condyle, kind of take multiple plugs. The reason part of this incision is really big and you see this big raw area bone is because they also needed a realignment surgery. But we can take some pretty significant areas of damage and replace it with an osteochondral allograft. And this can be in both young patients and sometimes in older patients who don't have more advanced arthritis throughout the entire part of their knee. And this is something called what we call a bio-uni or a biologic uni. So basically, the slide on the left shows a pretty significant area of cartilage damage. This is someone who, in many circumstances, would get like a partial knee replacement because it's completely worn down the bone. And this is what we call a bio-uni. And so we're able to take that cartilage graft, mold it to fit exactly in the area of damage. And now, instead of getting a metal and plastic partial knee replacement, we've really done this with cartilage. So there are certain settings where this can be done. So when we think about fresh osteochondral grafts, they really have about an 85 to 90% good to excellent results, but this is always in the right patient. It has to be done for the right kind of damage. It's a composite graft that heals and it has normal articular cartilage on its surface, but it can be expensive and there's availability issues sometimes that we have to deal with these cartilage grafts. And it also, what we call, burns bridges, because you make a pretty big hole to be able to put this graft in. And if it doesn't work, now we have to figure out how to deal with that hole that somebody has within their knee. Now, there's also another type of cartilage transplant called an autologous chondrocyte implantation. So this has undergone several generations of advancement. So the first generation from autologous chondrocyte implantation, it's still done that we first have to do an arthroscopy and we take a piece of cartilage out of somebody's knee and we biopsy it and we send it to the company that helps make these cartilage grafts. And we used to have to sew a patch and then inject cartilage underneath. And it was a bit of a tedious process, but that cartilage would then grow underneath the patch and eventually mature into relatively normal articular cartilage. And this is what we call a first generation ACI. So this is somebody who's got significant damage to their patella and what's called the trochlea, where their kneecap rides. And then we're able to sew the patch in the area damaged and inject cartilage underneath, and it gets glued, and that grows to normal cartilage. Well, now, starting in 2017, we've advanced this, and there's something called MACI. And MACI is really the third generation implant. And for this, the cartilage cells are grown directly on the membrane that we put in. So it's actually become much easier to do from a technical standpoint, from a surgeon standpoint, because we have to prepare the defect and it can be glued in place. And it certainly makes the entire process easier. So again, this is a similar type patient with damage to both the patella and the trochlea, pretty significant areas of damage. This is something we call a bipolar defect. So these can be tougher to treat because they articulate, they hit each other. And this is now this cartilage transplant all the way on the right, is the membrane is glued into place, and then that has to mature over time. So when we think about autologous chondrocyte implantation, again, it has about a 90% good to excellent result, especially in something like what's shown on the right, which is just a condyle. It grows to be articular-like cartilage over time, and it can be very durable. It's actually been shown that if you're doing well at 2 years with an autologous chondrocyte implantation, you can be doing well at 14 years. The downside is it takes a long time to mature. So unlike those osteochondral grafts that you just saw, which get placed with normal cartilage over top, this has to go through a very significant biologic maturation process, and it can take almost 18 months for it to fully mature, although typically by about 9 months, people are returned back to full activity. It's also expensive. There is a relatively high reoperation rate. Sometimes people can get some stiffness after surgery. Sometimes the cartilage can grow too much, and that can require an arthroscopy after surgery. So when you think about this, when we talk about surgery for cartilage restoration with cleaning it up, marrow stimulation, osteochondral grafts, autologous chondrocyte implantation. So, many people in the audience may be thinking, is this possible for me? And the thing is, these can be very complicated questions to answer, and especially without a full evaluation. So what do I think about when I'm trying to determine, is this a possibility? It's somebody's age, but it's really more their physiologic age and their chronologic age. It's the extent of the damage. Where is the damage? Or is it already bone on bone? When somebody really wears out both sides of their joint and it becomes bone on bone, it can be much harder to consider any of these type of techniques, and the success rate really starts to go down. What kind of biomechanical issues are there? Is there malalignment? Do they already have a meniscus that's been removed and won't provide a shock absorbing protection in the area damaged? So that can be an issue. And the bottom line is, although there are probably, again, a lot of people on this call that may be candidates for knee replacement, and they say, well, I would much rather save my knee. There are many times when knee replacement can be a better option because it's reliable and it will work to help somebody's pain and function, as opposed to an operation that may not do that if the damage is too significant. Now, I'm also just going to touch for a few minutes on meniscus injuries, because when we think about cartilage injuries, the meniscus is also a very big player in types of cartilage damage, and it affects the things we think about with cartilage restoration. So when somebody comes in and has injured their meniscus, it's many times an acute traumatic onset where they twisted or squatted. They can develop swelling or pain over the next day. People who we see with ligament injuries, like my athletes who tear their ACLs, many times have an associated meniscus tear. And you can get mechanical symptoms because this piece of cartilage can flip in and out of the area where it's supposed to be in the knee and cause pain. Now, we also see many patients with degenerative tears, and these are, you know, when I use this term older, I mean, first of all, that's a moving target. I just turned 51, so certainly, you know, that's not old, and we've got to consider what that means. But as people get more wear and tear on their knee, you can get a degenerative tear. And this can be an atraumatic history. There usually is still associated pain on the joint line in the area of the tear, and they may or may not have mechanical symptoms. And sometimes people say, you know, how did I tear my meniscus? And it can be either, it's like a pair of jeans that wears and wears, and eventually you get a hole in it, or you have some kind of minor trauma that creates a tear. So what do we do for meniscus tears? There's conservative treatment, just like all the other things we already discussed that can be done for cartilage damage. And then there's operative treatment, including partial meniscectomy, which is trimming out a piece of meniscus that's torn. There's meniscal repair. And then there are certain cases where we do meniscus transplants, which is another type of cartilage restoration where we put in a new meniscus. So why don't we repair everyone's meniscus who tears it? And the reason is because many of these meniscus tears don't have a blood supply. So just like we talked about the articular cartilage, which can't heal, many meniscus cartilage tears can't heal either because they're in an area without a blood supply. Now, if somebody tears their meniscus way in the periphery, and that's what this area that kind of looks like a spider is showing, the blood vessels in the area of the meniscus that has a blood supply. So those tears can be repaired, but the others many times can't because they won't heal. So when we think about conservative treatment, that's a lot of times for these degenerative type tears, either that occur either through minor injury or atraumatically. Things we can do include the anti-inflammatory medications, physical therapy to strengthen the muscles and the rest of the joint. I do use steroid injections commonly to calm down inflammation. And much of what we do is to try to figure out, is somebody's pain coming from a meniscus tear, or is it coming from arthritis? Because many patients who have a meniscus tear already have developed some arthritis in their joint, and it can be hard to know which one is causing their pain. So what do we do when it comes to steroid injection? It can provide excellent pain relief. As I mentioned before, we typically tell people that steroid injections last for 3 months. But in reality, when I see somebody who has an acute flare of pain from a meniscus tear, many times by decreasing that inflammation with a cortisone injection, it calms down the inflammation, they do a rehab program, and they're able to strengthen it, and then they can compensate and don't continue to have pain. So even though the injection does not heal the tear, sometimes it can calm down the inflammation of the joint to the point that people don't have symptoms and they can resume activities. When it comes to surgery, partial meniscectomy is the most common operation I do as a sports medicine knee surgeon. So basically, this is looking inside the knee. This is someone with a tear in the back of their meniscus. This is essentially using a little biter to remove that piece of meniscus that's torn that can irritate the knee, because that piece can flop around and it pulls on the capsule, which is the lining of the joint, and that causes pain. So essentially we're using a device both to bite, and this is a little shaver. It's like a little vacuum roto-rooter that kind of removes that piece of meniscus that's irritating the knee. So we're just trying to get to a nice smooth surface that won't irritate the knee in that area. And then when we're completed, there's a nice smooth surface, and then now that doesn't irritate the knee, and this is essentially what is done with a partial meniscectomy. Now, there's also meniscus repair. So again, meniscus repair is sewing the meniscus, which is restoring it back to normal. And in this case, you can see there's a little bit of green in the background, and that's the sutures, and that's to try to allow the meniscus to heal, and then you have to protect it after surgery. So what happens after you remove the meniscus? Well, this is over many, many years. Most patients do well, but over time you can develop arthritis. And back in the 70s and 80s, people used to have their entire meniscus removed through open surgery. And then a lot of these patients develop arthritis over time because it increases the contact pressure in that area, particularly if you have no meniscus. And I also see patients who suffer from what I call meniscal deficiency, which means they have pain from missing that shock absorber. Yes, they develop arthritis over time, but some of them just have pain because that shock absorber isn't working. And those are patients that can be candidates for something like a meniscus transplant. So a meniscus transplant is basically a cadaver frozen meniscus. This can be placed arthroscopically. It then gets repaired in place. And these patients can typically return back to activities at about 6 to 9 months. But it, again, has to be the right patient and the right candidate who can get something like a meniscus transplant. And it doesn't work when somebody already has advanced to bone on bone, because with that joint space narrowed, it'll just continue to grind the meniscus. So does it work? It can be about 80% successful in terms of good to excellent pain relief. But again, it has to be the right patient to get something like a meniscus transplant. So what about meniscus substitutes? Because I commonly get asked about this. We've tried all types of synthetic meniscus. There is a currently FDA-approved collagen meniscus implant that can be placed when someone has a smaller area of meniscus damage. But most of these have really not been shown to work over time. So although we're trying to figure this out scientifically, we really haven't come up with a perfect meniscus substitute that will work. And, are we going to be doing biologic total knees? I mean, this is a patient who I treated recently, young patient with several areas of cartilage damage that you can see on the left. In the middle, it's been prepared. And on the right, these are multiple MACI implants that have been placed in that knee. But again, it really has to be the right patient, and they can't have advanced x-ray changes, because usually when that happens, it can be someone who's better off getting treated with something like a knee replacement. So what's the success? Again, it can be highly successful for pain relief, but whether or not cartilage restoration surgery prevents future arthritis, particularly in our young patients who have smaller areas of cartilage damage, and does it prevent the need for knee replacement, are things that we're still trying to figure out through research. And really, my patients that are getting this type of surgery, we're talking about doing it for pain relief and function, but not because I know it's going to prevent them from having a problem in the future. So what can I do, in terms of saving your knee? I think the most important things, number one, it is important to stay active. I think that exercise, and again, particularly lower impact exercise and weight loss, really help to preserve your joint. If you've had a joint that's been injured, I think you really need to try to limit excessive impact. Nutritional supplements and some of these injections may provide some benefit. We know they provide symptomatic benefit, but they may also have some protective benefit on your cartilage. And this includes both the nutritional supplements and injections. And then we continue to advance these type of biologic technologies. I mean, there's all types of new cartilage transplant, there's new cartilage treatments, and all of this stuff continues to advance through scientific methods. But I will also tell you that it's really important to understand whether or not these things have been proven to work, because there are certain things that get advertised without much scientific proof that they work, and people have to be careful about spending their money and investing in things that really may not provide much benefit over time. The final thing is, if someone is on the call and they really don't know what's causing their knee pain, it is important to get a diagnosis to figure out what of any of these things can really benefit you. It's worth seeing a specialist. We have offices all over the tri-state area, and now in New York and Florida, and it's really important to see someone so that you can find out what's causing your pain to try to improve it. And that's really all I have in terms of formal lecture. And I don't know, Cassie, if you've been following what's going on with our chat box here. And
yep, thank you so much for the presentation. I will go through some of these right now, and you can keep your answers hopefully brief because we do have a lot coming in. So the first one, let's see, is elliptical machine better than a treadmill regarding pressure on knees?
That's a good question. And again, I think the answer overall in a nutshell is yes. There is no question that an elliptical creates less impact. And many people can do very well on a treadmill, as I mentioned before, if they don't have significant damage. But if you have an area of damage and you're continuing to pound on it, there's no question that it can accumulate additional damage. Now, I'm a sports medicine physician and surgeon, and my job is to get people back to sports. So I don't like to tell people to restrict activities that they're able to do. So it's always a balancing act. But at the same time, yes, I think that in terms of impact, elliptical is better if you have significant pain.
Okay. What are the rehab times for allografts? Are there any limitations after it healed?
It's a great question. So the answer is typically when I do an osteochondral allograft or any advanced cartilage restoration surgery, I have people on crutches for the first 6 weeks. So we're protecting their weight bearing, but they are allowed to move it. So they pretty much start immediate motion. So I tell them weight bear, motion's good, weight bearing's bad. After 6 weeks, I typically get them off crutches. By 3 months, they're functioning reasonably normally, but still undergoing a physical therapy program. And depending on the surgery, again, whether it's an osteochondral graft or a MACI, full return to activity is somewhere between 6 and 9 months. But the expectation is to try to get people back to full activities. I mean, I have some 17-year-olds who I see with cartilage damage who get osteochondral allografts who are returning back to full, collision sports and all these things. So it really depends on the circumstance, but the hope is to get people back to doing everything.
And what is the rehab for a microfracture?
So microfracture, again, requires a protected rehab. They're typically also on crutches for 6 to 8 weeks to try to allow that cartilage to grow in. And really, it takes somewhere between 4 and 6 months for people to return to full activity. As I mentioned, one of the biggest downsides of microfracture is when we look at the results, typically by about 4 years, and this is including young patients, people with small defects, the results start to deteriorate over time. So unlike some of the advanced cartilage surgeries, which seem to be durable over time, microfracture kind of deteriorates. But hopefully I answered your rehab question.
Yeah. I'm not sure if you said this in the presentation, but is PRP generally covered by insurance?
Right now, PRP typically is not covered by insurance. I know people like to ask a lot of questions about cost, and it can be, a little bit of a moving target. And I don't want anybody quoting me, but in general, I think at Rothman, for most of our products, it's about $900 for a single knee PRP injection, and that can change. And then usually it depends also on how many injections you're going to get, because there's everything from a single injection to 3 injections 3 weeks in a row, like the way we do visco supplementation. What I typically do is an injection and then another injection 21 days later, because when you look at the data, that seems to have a good efficacy and it doesn't require people to get 3 injections. But it is not typically covered by insurance.
Okay. Since you are in Bryn Mawr and Chalfont, is there any physicians in South Jersey that do these injections?
Yes, absolutely. And that's something that is certainly, if you reach out, and Cassie can try and help people get set up with appropriate physicians. We have a multitude of doctors that can take care of injections. I mean, advanced cartilage surgery, there's a few of us that we do, but in terms of many of the non-operative treatments, we have a lot of non-operative sports medicine specialists who are great at it. We have our other surgeons who are great at it. So there's plenty of opportunity for people who are calling in. I mean, the great thing about going virtual like this is we can really capture a much bigger audience, but and that's a great thing for educating, but obviously people want to stay local to where they live, so we can find opportunities for you.
Okay. What nutritional supplements do you recommend?
So as I mentioned in the talk, the one that has been, best proven with data is glucosamine and chondroitin sulfate. There are a whole variety of products, and most joint products that you find, if you go into GNC or you go into CVS or anywhere, most of those joint products have glucosamine and chondroitin sulfate. There are a lot of other products that have been looked at in terms of being anti-inflammatory, in terms of being cartilage protective, but as of the time, at least, that we did our study, they really didn't have a lot of proven literature to show that they worked. So that doesn't mean they don't work. It just means that there's not good proof.
There's a couple questions about lectures. One, do we have any upcoming ones about knee replacement, and how come doctors only talk about surgical methods? And I'll answer that. We do have other ones coming up on a whole slew of different topics. The reason why some doctors only talk about surgical methods is because they are surgeons, and that just might be the topic they are speaking on. But we have plenty of non-surgical physicians that do lectures on the non-invasive methods. And you can find those on our website, www.rothmanortho.com, and they have all the lectures listed at the bottom. Is leg press and Bosu ball okay for bone on bone?
I think if anything that's done in moderation and isn't causing significant pain or swelling, I think can be reasonable to do. So as long as you're doing things and they're not causing significant pain, I think that those exercises are fine. I also think that that's one of the other real benefits to getting into see a formal physical therapist. If you have damage, it can be one of the benefits of seeing the physician, getting a diagnosis, and getting into therapy, because they can really tailor your program to try to make sure that your exercise is benefiting you and not causing any damage.
Great, thank you. That is the majority of the questions. Everything else is getting a little too personable, but I'm sorry, I keep saying that, personal. Oh, real quick, do you think podiatrists would benefit from the knowledge of knee surgeons? Wait.
I mean, I'm not 100% sure that I understand that question, but there's no question that the entire, as I mentioned, when we talk about physical therapy and in everything I do, there's everything from the core and all abdominal strength, hip, knee, and foot and ankle. And they're all interrelated, and they all can cause problems with each other, and doing the appropriate exercises can help each other. So there's no question that podiatrists, because of what they're seeing in the foot and ankle, have a relationship with knee doctors like myself, because you have to be thinking about how these things are affecting you.
Yeah. All right. Someone keeps asking, where are your offices? Dr. Freedman sees patients out of Bryn Mawr and Chalfont, and he does surgery out of the Bryn Mawr Hospital, Bryn Mawr Surgery Center, and what's the second?
And also Riddle and Riddle Surgery Center and Bell Surgery Center as well.
Okay, all right. And I'm going to be sending this presentation to everyone. If there's any follow-up that needs to happen, you have my email address. You guys can send questions, or I will also send that VIP line again, which is 610-480-6584 if you need to schedule an appointment with Dr. Freedman. But thank you all for coming on here. This virtual lecture worked out well, so I appreciate it. Thank you, Dr. Freedman, for this.